thanks for the invite. I really appreciate coming and spreading the word about the Transperineal Biopsy Program. So just a bit about me. I grew up in Regina. I did my med school here in Saskatoon, and then I went to London, Ontario to become a radiologist. And at the time, I thought I was going to be a neuroradiologist, but...
I'm going to put you on this.
Oh, sure.
Okay.
Can you hear me better there? Yeah, perfect. I thought I was going to be a neuroradiologist, but when I was in second year of training, I met an Italian radiologist in London, Cesare Romanoli, and he convinced me that body radiology and doing procedures was really the best way to go, and I really haven't looked back. So I was very fortunate to get a fellowship in abdominal imaging and intervention at Harvard University in 2015. And I came back to Western Canada for 3 years in Red Deer, because I do tumor ablations as well as among biopsies, and they wanted to start a program up there, so they kind of recruited me to go there. Things didn't work out quite as much as I'd hoped to do procedures, so I decided to make the move back to Saskatoon to be kind of where I was training. My parents still live in Regina, and I haven't really looked back. You know, I'm part of a great practice. I really like being part of St. Paul's and everything. So my interest now is abdominal imaging, and including abdominal is pelvic. So prostate, MRI I'm an expert in. I'm also an expert in rectal MRI, and then doing the procedures. So tumor ablations, all the biopsies. If you unfortunately have an abscess in the abdomen, you need a tube in there. My job is to get the needle in and the wires and do it safely. So that's kind of how my practice has evolved. And honestly, for the last 5 years, the urologists have always been asking us, oh, hey, can we get transperineal biopsy going? And at the time, it was always thought that it was just a really hard procedure to get going, and there wasn't really anybody to do it. But to help Dr. Jana, I think people know Kunal Jana, he really wanted us to get this program to help everybody. And I started looking into it, and I'll kind of talk about the story, how it started. And once we go through it all, I can answer any questions. So yeah, next slide. So as I think most of you have had the old way, the transrectal biopsy. So unfortunately, prostate cancer is a very common cancer in men, or obviously in men, but it's the second most common cause of death in men, unfortunately. And 1 in 7 of us will be diagnosed with prostate cancer at some point in our life. In fact, they kind of think that as you get older, more and more of us will have some form of even an indolent prostate cancer. Maybe if you're into the 90s, almost everybody probably has some focus. And the mainstay for getting a prostate biopsy was doing a transrectal ultrasound, where there's a needle guide on the ultrasound probe itself, and then you pass the needle through the rectum into the prostate to get the samples. And then obviously it's not a clean area. It's impossible to do that procedure sterile, so there's a risk of infection. We would take 12 samples of the gland, 18 gauge, so just tubes of tissue about 3 centimeters long. We would take of the gland by passing this needle through the rectum about 12 times. So I think, as most people here have had it that way, it's not a great procedure, obviously. When I was training, we didn't use freezing, which is wild. But now we do, and now we've moved on to something better. But anyways, the cancer detection rate is about 42% with that procedure. And I'll get into a little bit how it's different now. So next slide, please. And then unfortunately, with the transrectal biopsy, there's complications, and there's rectal bleeding. So if somebody has a hemorrhoid, or even just if you're passing that needle through the rectum, we don't see the veins, but sometimes our needle can pass through it, and you can get quite a significant rectal bleed, where it requires a hospital admission, general surgery consultation, sometimes surgery to stop it if it's bad enough. It's pretty rare, but it does happen. You can have obviously blood in the urine, blood in your semen, and urinary retention. Just sometimes when that needle's close to the tube, the urethra is passing the center of the prostate gland, it can kind of spasm on us, and you can't pee. Or you have a blood clot in the bladder, and it plugs the exit of urine, and that can be an emergency. So, and then finally, and most concerning, is the infection rate. So it's estimated about 5 to 7% of men after getting a transrectal prostate biopsy will get some form of infection. About 2 to 4% of those men will require a hospital admission. And these infections can be very, very severe. It can happen very, very fast. So when we did it the old way, I would always warn them in. And I'm not sure if I've done one of your biopsies, I'm sorry, but if I have or not, but if it happens. But I'd always warn men not to be stoic. If you're not feeling right, even a couple days after the prostate biopsy, you need to seek medical attention quickly because it can make you very sick very fast. And I'm sure you've discussed, some people have had a very hard time recovering from this. It's essentially E. coli from the stool, goes in the bloodstream and spreads everywhere, and it's terrible. So so we can move on to the next slide. There we go. So transperineal biopsy. It's like, why didn't we do this a long time ago? Well, it was a way of doing it for a long time. Transrectal biopsy has been around since the late 80s. Transperineal has also been around that time. But it was always thought that it was too painful for men, so we'd have to do it with either a spinal anesthetic or general anesthetic. And as you know, getting a diagnosis fast is important. And if you had to put every man asleep in order to do this prostate biopsy, we just wouldn't be able to biopsy the amount of people that need one quickly. And it just was not felt to be feasible as a mainstay. So as physicians, we're always trying to balance risk versus benefit. Is this risk of infection at 5 to 7%? Is that worth it in order to biopsy enough men and get their diagnosis quick and in a timely fashion? And at the time, it was thought that transperineal was just not feasible to do enough men in time. Okay, you can go to the next. So, but it's actually a great Canadian story, to be honest. So in North York Hospital in Toronto, there's a group there that's has devised a new way to do transperineal biopsy. And that's the method that we're using here in Saskatoon. And they've actually looked at a study of 1,287 men who's had it done using local anesthetic only, using the transperineal biopsy probe. And then they compared men that have had the old way versus the new way. And then they looked over in the course to look at infection rates, other major complication rates, as well as how good is it compared to the old way, which I'll kind of discuss. So when I saw this paper, and I was fortunate to know a couple of the radiologists on it, I reached out to them and said, hey, look, I want to learn how to do this. And in October of 2022, I went out there and they taught me, and it was, So we'll keep going on the next slide. So in this paper, the main thing is they looked at 1,287 men. They compared transrectal versus transperineal biopsies only with local anesthetic. And they found their cancer detection rate was actually 49.8%, whereas with the old way, it's only 42%. So it's actually picking up more cancers than the old way. And this is because, we'll get into a little bit later, 9 to 10% of the men actually have the cancers only in the anterior part of the gland, which is really hard to reach the old way. So this is the area of the gland that we were missing. We just weren't able, the needle couldn't get far enough to pick up the cancers there. When I was training, it was thought that only 5% of cancers were in this anterior gland. But in recent years, we're finding out it's actually about 25% of men. That's where their cancer is. So that's important. That's a lot of people we were missing. In that study, only 4 patients had lower urinary tract symptoms, meaning they had burning when they peed, or a little bit of irritation or blood, feeling like they might have a bladder infection. But actually, only 1 out of the 1,200 men actually had a positive urine culture after the procedure. So their risk of infection rate is 0.08%. And that was, nobody had sepsis, nobody had a major complication, and nobody was admitted. One gentleman had a vasovagal response after the procedure where he fainted and fell, and he did go to emergency for like a workup, but he wasn't ultimately admitted. But it's not really a complication of the procedure itself. It was just, he had a fainting spell that was a bit more severe, which happens to anything we do. Okay, so next slide, please. So the method they use, they would give 1 single dose of antibiotics, and we are doing this as well, just as a prophylaxis. But it's not the same one that is treating the bugs in the rectum, and that's called a fluoroquinolone, and that's a type of antibiotic that has a lot of resistance that's growing. So that's also a reason to change to this. We don't want to be giving all these antibiotics. They actually stopped giving antibiotics completely now because the infection rate is so low, you don't even have to give it. As long as you're using sterile technique, you don't even have to take that prophylactic antibiotic, which is good also for the gut health and whatnot. So the dorsal lithotomy position, you're lying on your back and your legs are up in a stirrup, and that's called the lithotomy position. The probe still goes into the rectum, but it's a special type of ultrasound probe that is why we had to buy the machine. We freeze the skin, so above the rectum at the 1 and 11 o'clock, we freeze the skin there, and then we give you deeper freezing. And then we put in basically just IVs into the perineum. So you get 2 punctures in the skin only. And then through that IV, we can pass the needle in and out. So you're not getting your pokes in the perineum multiple times. You just really get a freezing poke and then a bigger IV poke. And then we work through those IVs. So we take the same 12 cores. So we're still sampling the prostate like normal. And it takes about 10 to 12 minutes to do the procedure. So about the same time as the old way. Because we have a group of ultrasound technologists helping me, they help get the patient in the room in the right position, clean the perineum for me. So when I come into the room, the needle time is really under 10 minutes to really get it done. I'm the fastest and most accurate because I've done the most, but my partners are all learned it and getting better because the learning curve is a little bit longer than the old way. But anyway, so this is kind of the setup in North York Hospital, which we've mimicked. So this is the surgical bed here with the stirrup. So you lie on your back and your legs are up in there. It's the ultrasound, the Canon ultrasound machine we're using, light, sharps, and so this is different than the old way where you're lying on your side and you can't really see much. And I think this is a bit of a barrier, which we can talk about where people are embarrassed. It's not something that men are not used to being in this position. When you come in the room here in Saskatoon, the ultrasound techs will get you in this position, and they will use gauze and tape to tape the scrotum up. So it's a bit more exposing than what men are more used to. So I try to warn people about this, but the benefits to you having to get this biopsy, I think, far outweigh the discomfort of this position. But anyways, and then we clean off the perineum with iodine, so it's nice and it's turned sterile. And then that's where we do the needle work. So you can go to the next slide. So this is the freezing of the skin. The anal canal is right there. So then the probe goes in and we put these 2 IVs right there. And then through those IVs, that's where we can pass the needle in and out. So again, you're not poking the perineum multiplied. You're not getting 12 pokes through the skin each time. And the beautiful thing about it is that when the procedure is done, if you can pee in 15 minutes, because we didn't pass the needle through the rectum, and if you can pee fine, you don't have any blood clots, you can go home in 15 minutes. Whereas before, we would keep you in the hospital for at least an hour to make sure you didn't have any rectal bleeding and all that stuff. So the procedure takes a little bit longer to do, but the recovery time is much easier on everybody. So the net benefit, in my opinion, is obviously way better. So you can go next slide. I don't know if this will work. So can you just hit the next slide? It should. Let's see if it
play the video?
Yeah. It might. If you just hit the next slide, actually, I think it automatically goes to the right spot. Oh, yeah.
An 18-gauge, 20-centimeter barred biopsy needle, taking a minimum of 10 cores.
So basically, we have those IVs, and then we can just direct the needle where we need to.
Apex,
So with the anterior part of the gland,
posterior apex,
then we do the posterior part of the gland,
and the right and left mid-lateral
and then we
cross
sweep laterally.
using a freehand technique.
And you can stop there. That's all it is. I just wanted to show that. So
Enable targeted procedures
you can stop there.
which have a higher yield.
Okay, so when they did this study, which is really good, they wanted to know how uncomfortable it was. Because remember when I said transperineal approach has been around for a long time, we always just thought you had to do it under general because it was so uncomfortable. Well, they did a standard pain severity score, and for all these men in this study, for 511 men in the study, they got a questionnaire, and they just said, like, rating what was the most uncomfortable part of the procedure. So the most uncomfortable part was reported the skin freezing, just that little needle right in the perineum. And that's unfortunately very uncomfortable until it goes numb. And the deeper freezing around the prostate was also uncomfortable. The biopsy themselves, some people still had some discomfort. And the probe going into the rectum, I think it's going to be uncomfortable. There's nothing we can do to make it better. The important thing is that out of 70 men in the study, had both types, and they reported them equivalent. They didn't think there was any difference between the two procedures for pain or tolerance. For us, we are using buffered lidocaine now for the skin infiltration. So the thought is that it's the acidity of the lidocaine that initially stings and burns until it goes numb. So we now add some sodium bicarbonate into that lidocaine, And that has actually really helped a lot. In the last year, we found that people are not having that stink, that really uncomfortable, and then it goes numb, and then you feel fine. So that's been helpful too. So next slide. So the Saskatoon program, like I said, I found this paper. I reached out to them. They were very grateful to let me just come and learn how to do the procedure. So I did that in October of 2022. Unfortunately, in our healthcare system, there's never funds to buy new fancy machines. So I just felt, talking to Jan, I was like, we got to get this going. The best way to do this is we just find some money. So I approached my partners at the Associated Radiologists and say, look, this is good for our group. This is good for our patients. This is good for the hospital. Can you donate? And so I was able to raise $80,000 donation from my partner group to get the machine. And then we took it to the St. Paul's Hospital Foundation and said, can you find a matching donor? And amazingly, Leo Barassa and Daphne Arneson did a matching donation, so we were able to buy the machine. And part of this I don't really have in here behind the scenes. I also had to convince the management and ministry to sign off on the service contract. So ultrasound machines are expensive to buy, but the servicing of them for the next 5 years, that contract's quite expensive, and something it changes every year how much it's going to cost. So I was able to get the SHA to agree to cover the service of it. So that way we were able to just buy the machine, get it here, and we've only bought it, and we're only using it for prostate biopsy only, so it lasts long. And yeah, so we purchased the Canon in March, April of 2023. Then there was a bit of a delay in getting the machine and supply issues and whatever. But by June, we had our first cases. So there was a bit of a write-up in the St. Paul's Foundation magazine about it. This is the actual machine itself. There's some images of me doing a targeted biopsy, which I'll get a bit later. You can go next. So first case we did in June of 2023. We now do 10 patients a week. Our old way, we were only doing 9 a week. So we're actually doing 1 more person a day. So we're even a bit faster, which is good. Because whenever you start a program, there's always going to be delays and things are slower. So we have a bit of a backlog right now in getting the wait list to get a prostate biopsy. But I'm kind of doing the blitz days to try to get those numbers back to a reasonable amount. Dr. Viswanathan and Dr. Jana really want people to have a prostate biopsy within 2 months. I think we're kind of at 3 to 4, so we're a bit behind right now, but we're working fast to get people faster. We've already done about 350 patients. I phoned Jana this week and I asked, have you heard of any complications or any infections? He says 0. Has not heard of anybody. That doesn't mean someone hasn't had a small low-grade cellulitis or something in the perineum, but it has not been any serious enough that they need to seek medical attention. So I haven't done a formal study and assessment to prove these numbers, but anecdotally it's wildly successful. And I asked them also about our diagnostic accuracy rate to see if it should be comparable to the papers published, and that is something that I will recruit like a medical student or a resident to help me. Once we get a nice data set of men, I want to make sure that our rate of diagnostic cancer detection rate is comparable to what it was before, or it should be higher. Okay, so let's keep going. So this is an image of the old way of doing the biopsy. At the top of the screen, that little black half moon, that's the transrectal ultrasound probe crystal. Then that really bright line is your rectal wall, and then this is the prostate gland here with some calcification in it. And that bright white line is us firing the gun and taking a sample. So we're sampling the peripheral zone of the prostate gland. That's where about 75% of cancers are, but we're cutting it kind of short axis through it. And then the anterior part of the gland is here. And you can see the needle tip is at least 1 centimeter short of not getting that anterior gland. And that's the standard transrectal biopsy there. So we can go to the next. This is the resolution of our Canon machine now, and it's much improved. So this is now, just because you're standing with your face up now instead on the side, this is the peripheral zone here. You can actually see markedly good imaging to just visualize the prostate gland. And then this is the transitional zone around the urethra, and the anterior gland is up there. So that's just how well the images look. It's way better. And the next slide over. This is now a transperineal. So imagine you're lying on your back here, and I have the probe in your rectum, and then the needle's coming through the perineum this way. So we're coming into the gland like this from your perineum, and then that's towards your bladder on that side. So this is the needle going into the peripheral zone where the majority of the cancers are, but we're now taking long axis samples. So you're getting a good 3 centimeter core where all like the cancer should be. So the detection rate is higher from that. And also this is the anterior part of the gland here. So we're able to get that needle up high and it hit those parts of the gland that we were always missing. So for those two reasons, I think you have a higher detection rate as well. So, and then we'll get now into MR fusion. Has anyone had a prostate MRI? It's become a prostate MRI. Has anybody had one? You have, yeah. It's growing more and more. Like in Ontario now, the majority of men are getting a prostate MRI before having a biopsy. In the past, MRI used to be used. You'd get your normal transrectal prostate biopsy. It was negative, but your PSA kept going up. So you have to go get an MRI to figure out, is there a lesion in that anterior gland that we haven't hit? But now, MRI is becoming so good at detecting small cancers that we can then, we needed to figure out how are we going to get these lesions. If we see it on the MRI, we often don't see it on the ultrasound. How can we make sure we're actually biopsying the right areas? So some smart people have developed what's called MRI ultrasound fusion. And what happens is you have your MRI at outside center. I'm able to import it into the ultrasound machine, and in real time using a GPS unit that goes right above your pelvis and on my probe, it maps the lesion on the MRI onto your prostate ultrasound images in real time and shows me a little target with a little X. And all I do is have to hit that X. So I'll show you some images of cases. So 1 second, let me see. Yeah, so the urologists usually, they want a specific sample of these lesions to figure out like how high grade is this cancer. Can they do specific treatment? Do they need surgery or waiting? Can we watch? But we weren't able to see them on ultrasound, so we would do what's called cognitive fusion. I would look at the MRI, I try to figure out the right spot on the prostate gland, and I just go for it and take a couple samples and basically like hope I got it. Now with the fusion, MR fusion, I can show real-time images that I hit that target beautifully. So it's great, and it has a much higher accuracy. So next slide. So this is someone's prostate, and this tiny little guy, it's 4 millimeters in the left peripheral zone, is a cancer. And it's only 4 millimeters, and they want us to do a targeted biopsy. So we'll go to the next image. So this is the same image, and I've circled on the MRI the target, and then with fusion, this, as I sweep in and out of the prostate, this little circle will show up at the exact spot where that cancer is on the MRI. Once the computer has figured out exactly the MRI and the prostate are at the exact same level. So we have to make sure everything's lined up properly, which takes a bit of skill. But then my needle is going through that exact 4 millimeter lesion. So we can go on the next slide. This is the same lesion here. This is the lesion circled on the MRI in real time on the ultrasound machine. And then this is the real-time ultrasound machine with the lesion circled, and my needle is that little echogenic spot right in the center. So I got it, like, and it was 4 millimeters. It was amazing. That was the first case I did. It's just, it was simple. It's like, it's so beautifully made. It's very good. So here, next case is another person. So this here is also a prostate cancer. There and there. And if you, next slide. So there it is, the prostate MRI. This is, I've marked it on the ultrasound, or I've marked it on the MRI images and important to ultrasound. And then in the ultrasound, it circles and comes up, and my needle's going right through it. So, you know, there's no doubt that we got the right spot. So, and then here again, it's just a different plane. The lesion's circled there, the lesion's right here, and my needle's going, you know, it doesn't have to be perfectly in the X, it just needs to be in the region. And honestly, when I take it, I take 4 or 5 samples still, just to not, you know, miss anything. So, and next, so where are we now? So we've already done about 350 patients because we do about 10 a day, or 10 a week, since last June. And that's doing the 12 cores for a systematic biopsy, as well as MR fusion biopsies. And I probably get asked to do about 4 of these fusion biopsies a week now. It's growing, because more and more men are getting prostate MRIs either ordered by the physicians or privately. Some people are going to and paying, and that's fine. And then the great thing is, even if you got your MRI in Calgary, you can bring it to me on a USB stick, and I can put it in there, and it doesn't matter where you got it. The best part here is no reported complications at all. That's 0 infections. If you think about it, there's 1 million people will get a prostate biopsy in the US, say. If they use all transrectal, that's 20,000 men will be admitted in the hospital for a severe infection doing it the old way. Like, the amount of money we will save over time, the lives we could save, because some men have unfortunately died from infection from prostate biopsy. And the best part is we're probably catching about 10% more cancers than we did before. And now we can do the MR fusion biopsies for everybody. So that's it. That's all I really had to talk about. So, yeah. I'm happy to answer any questions if I can.
That's 0 infections.
Yeah, it's remarkable. Yes.
Yeah, a couple. So the positioning of your needles.
Yes.
Is that basically, those of us that had brachytherapy, is that basically in the same spot?
Basically, exactly. Instead of brachytherapy, they use the template, and then they can. We just do it freehand.
Yeah. Well, you only put it in two, not
Exactly.
dozen or
You
whatever.
basically want to be high enough so that needle doesn't actually go down into the rectum, because it's close, like the anatomy. But the nice thing is where those needles are going, there's not a lot of blood vessels there that we have to be even concerned. So we actually just put them in blind, because there's some veins, but there's no major artery there. So it's really safe. And then, again, the needle is never going into the rectum. It's just going into the subcutaneous fat and then the prostate gland. So.